The topic of my talk is retinoblastoma. I'll review some of the basics and go over a few new developments. I have no financial relationships relevant to this presentation. Why know about retinoblastoma anyway? Well, remember Eagle's rule number 1. If you want to get sued, misdiagnose cancer in a baby. In Europe and North America, retinoblastoma is the most common primary intraocular tumor in childhood. Worldwide, retinoblastoma actually is the most common primary intraocular tumor, as Dr. Tara Cavella concluded in this editorial in the British Journal of Ophthalmology. He estimated that there were approximately 1,000 more cases of retinoblastoma yearly in the world than uveal melanoma, which often is said to be the most common primary intraocular tumor. About 2/3 of uveal melanomas arise in Caucasians of European descent, who comprise about 13% of the world's population. Han Chinese and Bengalis make up about 1/4 of the world's population, but they only have 8% of the uveal melanomas. Retinoblastoma is rare. There's only 250 to 300 new cases yearly in the United States. There are 1,500 to 2,000 new cases yearly in India. Retinoblastoma is a major cancer success story in Europe and the United States. Retinoblastoma is a highly malignant neoplasm that's almost invariably fatal if untreated. The survival rate in 1900 was only 5%. This had improved to 30% by 1930 and 95% by 1990, reflecting advances in medical education and therapeutics. Today, very few children in developed countries actually die from their primary retinoblastoma. Second cancers are now the most common cause of death in these patients. Unfortunately, worldwide, survival still remains only 50% due to poor access to health care and presentation in the late stages of the disease. This child from Tibet has massive orbital involvement due to extraocular extension. Retinoblastoma is the most common primary intraocular tumor of childhood. Its incidence is 1 in 15,000 to 20,000 births. The mean age at presentation is 18 months. Most cases develop by age 4. Both sexes are affected equally, and tumors involve both eyes in 1/3 of cases. Some patients have a family history of the disease, and bilaterality indicates a germline mutation that can be transmitted to offspring. Rarely, the tumor can be an incidental finding on a routine examination, but typically it presents with a white pupillary reflex or leukocoria, and patients also may have strabismus. In the past, leukocoria was termed the amaurotic cat's eye reflex. In 1767, Hayes stated that the pupil in retinoblastoma has a bright look, somewhat resembling a cat's eye in the dark. Not infrequently, the abnormal pupil is first noted in family photos. Note the abnormal reflex in the left eye of this blonde child. She was not adopted. She is an albino who also has retinoblastoma. When I saw this photo of my technician's grandson, I told her he needed an eye examination. Fortunately, his left fundus was totally normal. This is a nice example of physiological leukocoria. The abnormal pupillary reflex is caused by the optic nerve viewed from an appropriate angle. Retinoblastoma can have other more unusual clinical presentations. Pseudoinflammatory signs include a pseudohypopyon of tumor cells in the anterior chamber, or a septic orbital cellulitis. Other rare presentations include neovascular glaucoma and heterochromia iridis, orbital tumors due to massive extraocular extension, and rarest of all, congenital retinoblastoma. This clinical photo shows a relatively quiet eye with a pseudohypopyon composed of tumor cells in a case of diffuse infiltrative retinoblastoma. Diffuse infiltrative retinoblastoma is the least common growth pattern in retinoblastoma patients. It often presents with pseudoinflammatory signs. Due to sporadic somatic mutations, such tumors are always unilateral, and they typically present in older patients with a mean age of 6 years. In most instances, there is no distinct tumefaction. This photo shows a teenage boy with diffuse infiltrative retinoblastoma who presented with seeds of tumor in the anterior chamber. Diffuse thickening of the retina without calcification is seen in the photomicrograph. This child was admitted to a children's hospital diagnosed with orbital cellulitis. The patient actually had a retinoblastoma that had produced neovascular glaucoma and extensive necrosis of ocular structures. A large pseudohypopion of tumor cells is present. This eye from a patient with aseptic orbital cellulitis shows a necrotic hemorrhagic tumor. Fluid neovascularization blankets the necrotic iris, and the lens is dislocated due to ciliary body necrosis. Here's another patient that presented with inflammatory signs and a hyphema. Pathology shows extensive intraocular necrosis and a dislocated lens. Here's another patient with severe neovascular glaucoma and inflammation. This patient from India presented with a massive orbital tumor secondary to extraocular extension. This exceedingly rare case of congenital retinoblastoma presented with a massive hyphema and a perforated cornea. This photomicrograph shows characteristic calcific foci of necrotic retinoblastoma cells in a Tysco eye with extensive necrosis. The findings are consistent with spontaneous regression of the tumor. This probably was caused by severe neovascular glaucoma. The retina is a peripheral colony of brain cells. Therefore, it's not surprising that retinoblastoma has a brain-like or encephaloid appearance grossly. Endophytic retinoblastomas arise from the inner layers of the retina and invade the vitreous. The retina remains attached. Endophytic retinoblastomas may be confused with inflammation. They arise from and destroy the retina, which remains attached. This photomicrograph shows a large endophytic tumor invading the vitreous cavity. Exophytic retinoblastomas arise from the outer retina and often cause high bullous retinal detachments. They may cause anterior displacement of the lens iris diaphragm and secondary angle closure due to a pupillary block mechanism. This photo shows anterior displacement of the lens iris diaphragm due to a high bullous detachment. Histopathology. Retinoblastoma is a highly malignant small blue cell tumor. It is composed of poorly differentiated neoplastic cells that have scanty cytoplasm. Necrosis in apoptotic cells are common, and there are numerous mitotic figures. The retinal tumor appears blue under low magnification. Retinoblastoma cells tend to undergo necrosis and lose their basophilic DNA when the cells have extended approximately 90 to 110 microns from a nutrient vessel. This produces cuffs of basophilic viable cells separated by sheets of eosinophilic necrotic tumor. Cuffs and sleeves of viable tumor cells separated by necrosis are seen in these photomicrographs. Retinoblastoma appears pink, blue, and purple in sections stained with H&E. The viable tumor is blue or basophilic, and the necrotic tumor is pink or eosinophilic. Purple foci of dystrophic calcification develop in the necrotic areas. Detection of these calcific foci with imaging can help to establish the diagnosis clinically. Retinoblastoma shows varying degrees of retinal differentiation. These include two types of rosettes and photoreceptor differentiation called florets. Wright rosettes are the most primitive. They represent neuroblastic differentiation and are also found in neuroblastomas. They don't have a lumen and contain a central tangle of neurofilaments. They are named after James Wright, a pathologist at the Massachusetts General Hospital. Flexner-Wintersteiner rosettes are the classic rosette found in retinoblastoma. They are named after Simon Flexner, a pathologist at the University of Pennsylvania, and the Austrian ophthalmologist Hugo Wintersteiner. Flexner-Wintersteiner rosettes represent early retinal differentiation. They have a central lumen that corresponds to the subretinal space, and the surrounding cells are joined by intercellular connections that resemble the retina's external limiting membrane. Many Flexner-Wintersteiner rosettes typically are found in eyes enucleated from very young infants. Retinoblastomas become less well differentiated with increasing age. In this study, the mean age of patients with numerous Flexner-Wintersteiner rosettes was 8.5 months. In contrast, the mean age of patients with poorly differentiated tumors was 34.5 months. Florets represent the most advanced degree of retinal differentiation. The term floret was applied to photoreceptor differentiation by Mark Cho, Ben Fine, and Lorenz Zimmerman in 1970. The bouquets of pink flowers forming these florets are composed of neoplastic photoreceptor inner segments aligned along a segment of neoplastic external limiting membrane. Foci of photoreceptor differentiation occur in about 20% of retinoblastomas. It typically is found in an area of viable tumor that appears relatively eosinophilic compared to retinoblastoma. A benign tumor composed entirely of florets is called a retinoma or retinocytoma. Clinically, these tumors often have a translucent fish flesh-like appearance and have abundant calcification that's been likened to cottage cheese. They are often surrounded by a band of RPE atrophy. In the past, these non-progressive lesions were thought to be retinoblastomas that had undergone spontaneous regression, because some resembled tumors that had regressed after treatment. In 1982, Brenda Galli suggested that these lesions actually were a benign manifestation of mutations in the retinoblastoma gene and called them retinomas. The term retinocytoma was used in a subsequent pathology study from the Armed Forces Institute of Pathology. In 2007, Dr. Helen Damaris in Brenda Galli's laboratory investigated expression of the retinoblastoma gene in retinoma and photoreceptor differentiation using a variety of molecular genetic techniques. She found that identical to retinoblastoma, both copies of the RB1 gene were lost or inactivated in retinoma. Since both copies of the RB1 gene are lost in retinoma retinocytoma, additional mutations are necessary for progression to retinoblastoma. An RB1 mutation is not enough. She also suggested that retinoma or retinocytoma is a precursor lesion for retinoblastoma. Retinoma retinocytoma has been observed to undergo malignant transformation into retinoblastoma. This case was detected on preschool screening in March of 1984. The tumor was observed for several years and did not progress. However, marked tumor enlargement consistent with malignant transformation was observed in January of 1987. The eye was enucleated, and histopathology shows a characteristic retinoblastoma composed of cuffs and sleeves of viable basophilic cells. The endophytic retinoblastoma rests on the inner surface of the eosinophilic precursor retinocytoma. Photoreceptor differentiation consistent with the precursor retinoma retinocytoma is present in the basal part of the lesion. 5 to 10% of retinoblastomas are familial cases with a definite family history. Less than 5% occur in patients with 13q- syndrome. These cases initially suggested that the retinoblastoma gene was present on chromosome 13. The great majority of retinoblastomas occur sporadically. 3/4 of the sporadic cases are caused by somatic mutation. However, the remainder represent new germline mutations that potentially can be transmitted to offspring. The retinoblastoma or RB1 gene is located on chromosome 13 in the 13q14 band. It is the paradigmatic recessive oncogene. It encodes RB1 protein that regulates the cell cycle. Lack of RB1 protein activates the E2F transcription factor. Some oncogenic viruses make proteins that inactivate the RB1 protein. As noted before, most cases of retinoblastoma are sporadic and occur in patients who have no family history. 3/4 of the sporadic cases are caused by somatic mutations, and the remainder are caused by new germline mutations. Familial cases are heterozygous for the RB1 mutation. A second hit or gene inactivation in a retinal cell causes the tumor. Retinoblastoma carriers with RB1 mutations are at risk for second non-ocular tumors. These include osteogenic sarcomas and pineal gland tumors. In normal individuals, 2 normal RB1 genes code for a double dose of RB1 suppressor protein. Heterozygous carriers of retinoblastoma have a single functional retinoblastoma gene. Malignant transformation develops when the remaining functional copy of the gene is lost or inactivated. The mutational rate has been estimated to be 10 to the -7th or higher. It has been estimated that 10 to the 8th mitoses are involved in the development of the retina. This is 1 order of magnitude greater than the spontaneous mutation rate of the RB1 gene. Therefore, there's an excellent chance that a retinal cell in both of the patient's eyes will lose its remaining functional copy of the gene and undergo malignant transformation. In addition, multiple tumors may develop in a single eye. Sporadic somatic retinoblastomas are caused by two successive hits or gene inactivations in a single retinal cell. Such tumors are invariably unilateral and unifocal and occur at a mean age of 24 months. Only a single hit or gene inactivation is necessary to form a tumor in a patient with a germline mutation. Tumors in patients with germline mutations are often bilateral and may be multifocal and occur at a younger age, on average 12 months. To repeat, tumors due to somatic mutations are always unilateral and occur in older children. Tumors due to germline mutations typically occur in younger children and are often bilateral. Although the RB1 gene is recessive at the molecular level, retinoblastoma is transmitted in what appears to be an autosomal dominant fashion. Mating a normal individual with a heterozygote yields 50% normals and 50% heterozygotes that can go on to develop the tumor, mimicking dominant transmission. Patients who have germline mutations in the RB1 gene have a 20 to 50% chance of developing a second tumor in 20 years. These include osteogenic sarcomas, chondrosarcomas, and other soft tissue sarcomas, malignant melanomas, and carcinomas of the upper respiratory tract and skin. This photomicrograph shows an osteogenic sarcoma that arose in the field of external beam radiotherapy in a patient with an RB1 germline mutation. The incidence of osteogenic sarcoma is also 500 times greater outside the field of radiation. Patients with germline mutations are also at risk for developing retinoblastoma-like tumors of the pineal gland called pineoblastomas. This association has been called trilateral retinoblastoma. The presence of bilateral retinoblastomas indicates that a patient has a germline mutation. Unilateral involvement does not exclude heritable disease, however, because only 60% of familial cases have bilateral tumors. It is accepted dogma that loss or disruption of both alleles of the RB1 gene is responsible for initiating all cases of retinoblastoma. These typical cases of retinoblastoma are designated as RB1 negative tumors. However, an RB1 mutation cannot be found in approximately 2% of patients who have unilateral tumors and a negative family history for retinoblastoma. The tumors in these patients are designated as RB1++. Rushlow and co-workers examined more than 1,000 unilateral retinoblastomas and found that 2.7% of them were RB1++ tumors. The RB++ tumors have unusual features. They are poorly differentiated, they behave aggressively, and they're diagnosed at a very early age. 4.5 months compared to 24 months for non-familial unilateral RB-minus tumors. The RB++ tumors are always sporadic and unilateral, and siblings are not at risk for developing tumors. The cytology of the RB++ tumors is also unusual. They're composed of undifferentiated cells that have large, prominent round or oval nuclei with multiple nucleoli. Apoptosis is common, there is little calcification, and no Flexner-Wintersteiner rosettes are present despite the young age of the patient. As noted before, numerous Flexner-Wintersteiner rosettes typically are found in retinoblastomas enucleated from young infants. An RB-, and an RB++ tumor are compared in these two photomicrographs. Note the large oval nuclei with prominent nucleoli in the ++ tumor. Many RB++ tumors have high levels of MYC oncogene amplification, shown by fluorescent in situ hybridization in this photo. MYC may be the driving force for this type of retinoblastoma. These photomicrographs compare an RB-, and an RB++ tumor stained with an immunohistochemical stain for RB1 protein. The nuclei of the RB++ tumor stain positively for RB1, while the nuclei of the typical retinoblastoma caused by RB1 mutations do not stain. Normal retinal cells next to the RB negative tumor serve as a positive internal control. In recent years, Dr. Jesse Berry from Los Angeles has reported on the use of DNA in aqueous humor as a surrogate tumor biopsy for retinoblastoma. Dr. Burry obtained aqueous humor from 3 cases of retinoblastoma and analyzed it to determine if it contained sufficient DNA to perform genetic analysis. Cell-free DNA was isolated from the aqueous humor. This study demonstrates that tumor-specific DNA is present in the aqueous humor of RBIs and can be safely biopsied and evaluated. This figure from her paper showed that the DNA from the aqueous humor and the tumor correlate well. The results suggest that aqueous humor can serve as a surrogate tumor biopsy when RB tumor tissue is not available. This will allow for analysis of tumor-derived DNA in RBIs undergoing salvage therapy that have not been enucleated. In the future, it may allow clinicians to diagnose retinoblastoma in situations when the diagnosis is unclear. It also may help to determine whether certain chromosomal abnormalities or mutations in the RB1 gene correlate with prognosis or a response to therapy. A subsequent study showed that gain of chromosome 6p detected in DNA in the aqueous humor was associated with a 10-fold increased odds of enucleation. Risk factors for metastasis. Conventional risk factors for metastasis in retinoblastoma include extraocular extension and orbital invasion, massive posterior uveal invasion, optic nerve invasion, including retrolaminar invasion and extension to the surgical margin, and anterior segment involvement. The significance of anterior segment involvement is somewhat unclear because patients typically have other high-risk features. A study by the Children's Oncology Group investigated the role of adjuvant chemotherapy in eyes with unilateral retinoblastoma with and without histopathologic risk factors. High-risk histopathologic features that were indication for adjuvant chemotherapy included massive posterior uveal invasion, retrolaminar optic nerve invasion, and any degree of concomitant choroidal and optic nerve involvement. Retrolaminar invasion of the optic nerve head is a major risk factor and is an indication for adjuvant chemotherapy in most centers. Essentially, if the tumor is behind the lamina corbosa, it's outside the eye. Massive posterior uveal invasion is another high-risk feature. Massive has been defined as an area of choroidal invasion greater than 3 millimeters in maximum diameter or involving the full thickness of the choroid. This focus of choroidal invasion is massive because it's greater than 3 millimeters in largest diameter. The results of the COG study were published in 2019. Patients with the poorest prognosis had greater than 3 millimeters of peripapillary choroidal invasion combined with 1.5 millimeters or greater of retrolaminar optic nerve invasion. This case in the COG study from Wills led to a change in the study's protocol and to the standard procedure for grossing eyes with retinoblastoma. In the initial COG protocol, only the central pupil optic nerve segment of the globe was submitted. This patient had no high-risk features in the PO segment and did not receive chemotherapy. Unfortunately, the patient developed distant metastasis several months later. The remaining wet tissue was retrieved and the culottes were sectioned and submitted. A massive area of choroidal invasion measuring more than 3 millimeters in diameter was found in one of the culottes. This was not evident during the initial gross dissection. We now routinely breadloaf and submit both culottes. The entire eye is now submitted, the PO segment, both breadloaf culottes, and the transverse section of optic nerve, including the surgical margin. The majority of retinoblastomas are treated with enucleation or chemotherapy. Radioactive plaques and cryotherapy are used as supplemental therapy in some cases. External beam radiotherapy largely has been abandoned due to the danger of secondary tumors in patients with germline mutations. When I started in ophthalmic pathology, most retinoblastomas were treated by enucleation. In recent years, fewer eyes with retinoblastoma are undergoing primary enucleation. Many cases are being treated with chemotherapy. Several types of chemotherapy are used to treat retinoblastoma. Intravenous chemotherapy can be used to shrink large tumors, allowing subsequent consolidation therapy, a process called chemoreduction. Adjuvant chemotherapy using vincristine, etoposide, and carboplatin is administered intravenously after high-risk histopathologic features are identified in the nucleated specimens. This is effective in preventing metastases and pineal tumors. Intra-arterial chemotherapy, or IAC, delivers chemotherapeutic agents like melphalan directly into the ophthalmic artery. IAC was developed by Kaneko in Japan and promoted by David Abramson in the United States. It is used extensively by the Wills Eye Oncology Service, and it effectively controls many tumors. IAC does remain somewhat controversial, however. There may be an increased risk of metastasis because the drug is delivered directly to the eye, and high-risk features that would have been indications for adjuvant systemic chemotherapy are not detected. In recent years, Dr. Francis Mounier has popularized intravitreal chemotherapy. This has proved to be a safe and effective therapy for vitreous seeds, a major cause of treatment failure. The procedure does not predispose to extraocular extension if performed carefully. I was interested in reviewing recent changes in treatment. I reviewed 35 eyes enucleated from patients with retinoblastoma that were accessioned by the ophthalmic pathology laboratory at the Wills Eye Hospital between July 2018 and December 1, 2021. 25 or 71.4% of these eyes had been treated previously. Prior therapeutic interventions included intravenous chemoreduction, intraarterial chemotherapy, intravitreal chemotherapy, plaque, cryo, transpupillary thermotherapy, PRP and Avastin injections for neovascular glaucoma, and a single remote instance of external beam radiotherapy. Many patients received a variety of prior treatments shown here in this table. 18 patients received intraarterial chemotherapy, 14 chemoreduction, and 6 received both chemoreduction and intraarterial chemo. 6 patients were treated with radioactive plaques. Indications for enucleation included recurrent or chemo-resistant tumors, eyes with no view of the fundus due to opaque media, neovascular glaucoma, chronic retinal detachments, ptysis bulbi, or painful eyes with no visual potential. The eye shown here became resistant to chemotherapy. There was no view of the fundus in this eye due to a dense cataract. Histopathology shows an anterous subcapsular fibrous plaque and cortical degeneration, including liquefaction and Morgagnian globules. More than half of the previously treated eyes contain no viable intraocular tumor. Several other eyes contain only small foci of residual viable retinoblastoma. Most of the tumor blanketing the ciliary body in this case was necrotic. Only a few small aggregates of viable cells are present. Most of the tumor in this eye was the necrotic cloud. Histopathology shows that the cloud is composed of totally necrotic eosinophilic cells and cells with degenerated apoptotic nuclei. 2 of the previously treated eyes had retrolaminar optic nerve invasion, a high-risk feature. In one of these cases, there was no viable tumor inside the eye, but there was massive involvement of the retrolaminar optic nerve. This photomicrograph shows the massive retrolaminar optic nerve invasion. A plaque of glial cells is present on the optic nerve head. The tumor extended to the surgical margin. Enucleation was performed after an MRI disclosed probable diffuse leptomeningeal involvement. The patient subsequently died from the tumor. A 3-month-old patient developed acute inflammation, massive intraocular necrosis, and aseptic orbital cellulitis after receiving a single treatment of intravenous chemotherapy. Another patient treated elsewhere developed necrosis, vitreous hemorrhage, and ptysis bulbi after chemoreduction. Note the cataract in the histopathology. A patient treated at another hospital developed vitreous hemorrhage and attractional retinal detachment after intraarterial chemotherapy. The recurrent tumor in one patient was thought to be an RB++ retinoblastoma. That tumor contained unusual cells with large oval nuclei with nucleoli, and the nuclei were immunoreactive for RB1 protein. 9 of the eyes had neovascular glaucoma. More than 3/4 of the treated eyes contained treatment regression scars. These comprise aggregates of calcified tumor cells within a delicate glial matrix. Bone formation was noted in the treatment regression scar of a patient treated 20 years previously with external beam radiation therapy. This is seen in the photomicrograph. Characteristic aggregates of calcified tumor cells are seen in the regression scar above. In this instance, the bone does not appear to be the result of osseous metaplasia, the RPE. In several cases, small foci of well-differentiated tumor resembling retinoma or retinocytoma occurred at the margin of treatment regression scars. This eye also contains a significant amount of residual chemo-resistant tumor. The well-differentiated tumor appears bland without mitoses or apoptosis, in contrast to the residual chemo-resistant tumor that appears significantly anaplastic. Other findings in the treated eyes included chronic retinal detachment, retinal RPE and choroidal atrophy secondary to chemotherapy, and chorioretinal atrophy and scars secondary to cryotherapy, plaque brachytherapy, and/or panretinal photocoagulation. Chronic retinal detachments are seen in these macro photos. The eye on the left has a treatment and regression scar. This macro photo shows severe chorioretinal atrophy secondary to chemotherapy, shown here under higher magnification. Corresponding histopathology shows total atrophy of the choroid. The retina is reduced to a thin layer of glial cells with scattered melanophages. This eye has severe atrophy of the pars plana ciliary epithelium and the iris pigment epithelium. This is also seen in the corresponding photomicrograph. Another case with severe iris atrophy is seen in this photograph. The iris stroma contains numerous clump cells, and the sphincter muscle and pigment epithelium are markedly atrophic. A focus of severe choroidal atrophy is seen near the ora serrata in this case. All of the retinal pigment epithelium also appears markedly atrophic. Severe choroidal atrophy is evident in the photomicrograph. Clumps of pigment are present in the subretinal space. This macro photo of another eye shows chorioretinal atrophy and patches of pigmentation. The outer retinal layers in the RPE are severely atrophic, and a lipogranulomatous exudate fills the subretinal space. Mild non-granulomatous choroiditis also is present. Severe chorioretinal atrophy also is present in this case. Histopathology confirms the presence of severe outer retinal, RPE, and choroidal atrophy. Atrophy also involves the inner retinal layers. Another example of severe RPE and choroidal atrophy is seen in this macro photo. The RPE and the photoreceptors, including the outer nuclear layer, are absent, and a chorioretinal adhesion is present. Multiple chorioretinal scars consistent with prior panretinal photocoagulation for neovascular glaucoma are seen in these photos. 10 years ago, during the early stages of intraarterial chemotherapy, we examined 8 eyes enucleated after IAC. We found birefringent foreign material in the lumina vessels in 5 of the 8 eyes. The foreign material included cellulose fibers and synthetic fabric fibers. We have found no intravascular foreign material recently. We did find an epibulbar foreign body granuloma on the posterior surface of an eye that presumably was related to prior plaque therapy. 28% of the retinoblastomas received recently had received no prior therapy and were enucleated primarily. These included a number of eyes with very large group E tumors. It is possible that delayed treatment due to COVID-19 may have been a contributing factor. One untreated patient presented with extensive intraocular necrosis, a hyphema, and aseptic orbital cellulitis. Hemorrhage in the totally necrotic tumor and a dislocated cataractus lens are seen in the pathology photos. 2 untreated patients had bilateral tumors. One had 13q- syndrome, and the other child's father had retinoblastoma. 4 of the 10 untreated patients had high-risk features. 3 of the patients had retrolaminar optic nerve invasion. One of these patients also had massive choroidal invasion, and the remaining patient had massive choroidal invasion with extraocular extension. This eye with a large retinoblastoma had retrolaminar optic nerve invasion, shown here under higher magnification. This large tumor massively invaded the posterior choroid and extended extraocularly. The tumor in the choroid and the focus of extraocular extension are seen in this photomicrograph. In conclusion, more than two-thirds of recently accessioned retinoblastoma eyes were treated previously. More than half of these treated eyes contain no viable tumor. Treatment regression scars, retinal, RPE, and choroidal atrophy are common findings related to prior therapy. We found no intravascular foreign bodies. 8% of the previously treated cases had high-risk features compared to 40% of the untreated cases.
In conclusion, I'd like to briefly review the differential diagnosis of retinoblastoma. The differential diagnosis of retinoblastoma includes a variety of potentially simulating lesions. Ocular toxocariasis is caused by the nematode Toxocara canis. The condition is unilateral and tends to occur in older children. An abscess composed of eosinophils is found in the vitreous. The worm may be found if serial sections are performed. PFV, or persistent fetal vasculature, previously was called PHPV, or persistent hyperplastic primary vitreous. The disorder is present at birth, and the affected eye typically is microphthalmic. Inwardly drawn ciliary processes attached to a retrolental plaque are a characteristic finding. Shunt vessels on the iris and other persistent fetal vessels often are present. Coats disease is unilateral and non-familial, with a peak incidence toward the end of the first decade. Affected patients have exudative retinal detachments with lipid-rich subretinal fluid caused by abnormal leaky retinal vessels. Retinal exudates are common, and there are areas of capillary non-perfusion. The subretinal fluid contains cholesterol clefts and foamy histiocytes. Findings resembling bilateral Coats disease are found in patients with facioscapular humeral muscular dystrophy. Like retinoblastoma, retinopathy of prematurity typically is bilateral and occurs in infants but is not congenital. Stimulated by supplemental oxygen, new vessels arise at the junction between the non-vascularized peripheral retina and the posterior vascularized retina. Vitreoretinal neovascularization can cause a mass of folded retina that can be confused with retinoblastoma. This was called retrolental fibroplasia when it initially was observed. Embryonal medullopithelioma is a rare primary intraocular tumor that usually arises on the inner surface of the ciliary body. The tumor has also been termed dictyoma. It usually is found around age 4 or 5. Cystic spaces in the tumor seen in this photo are a characteristic feature, and the neoplastic cyclitic membrane of tumor cells is often present behind the lens. Benign and malignant variants are recognized, and these may be teratoid or non-teratoid. Very rare cases occur in adults, and fatalities usually are associated with extraocular extension. This photomicrograph shows a teratoid medullopithelioma on the inner surface of the ciliary body. Cystoid spaces are present, and a cyclitic membrane of tumor cells is present on the posterior surface of the lens. The tumor is classified as teratoid because it contains multiple foci of hyaline cartilage. The tumor contains polarized bands of neuroepithelium that resemble the embryonal medullary epithelium. The tumor also contains loosened pools of hyaluronic acid that have been termed neoplastic vitreous. The acid mucopolysaccharide stains with colloidal iron, and the staining is abolished by pretreatment with hyaluronidase, confirming that the material is hyaluronic acid. Teratoid medullopitheliomas contain heteroplastic elements including hyaline cartilage, muscle, rhabdomyoblasts, and brain-like tissue. The cartilage was visible clinically in the case shown here. Medullopithelioma is associated with the pleuropulmonary blastoma syndrome and mutations in the Dicer1 gene. Progressive giant cell astrocytomas occur in some patients with tuberous sclerosis complex. The typical astrocytic hamartomas in tuberous sclerosis are non-progressive. Bilateral masses of malformed retina that have been termed pseudogliomas occur in Norris disease, which is inherited in an X-linked recessive fashion. Many patients have intellectual disabilities, and many develop progressive hearing loss. Shortly after birth, patients with incontinentia pigmenti develop a vesiculobullous eruption rich in eosinophils. They then develop a secondary marbleized pattern of skin pigmentation that's responsible for the disorder's name. Incontinentia pigmenti is inherited as an X-linked dominant trait and is lethal in males. Affected females have peripheral capillary non-perfusion and can develop retinal detachments caused by vitreoretinal neovascularization. They can also have dental and CNS abnormalities. The disease is caused by mutations in the NEMOIKK gamma gene on XQ28.
Thank you for your attention.